Smoke check. So good morning all. So as a part of practical orientation classes, today we are going to discuss how to approach a cardiac case in pediatric age group. So before heading into the topic proper, let's have a in general overview of how to take a case. See, in pediatric case presentations, most of the times, in almost 80% of the times, you can come to a diagnosis by history itself, and physical examination is mere for confirmation of your history. I mean, you need to look for the signs which correlates with your history. So history taking plays a crucial role. I mean, it takes a lot in a pediatric age group. So one need to take a elicit a good amount of history. So with this background, let's have an approach how to have a in general approach to a cardiac case. So in the basic purpose of the history taking is, we'll later on we'll discuss about the physical examination part. First, history taking, the basic purpose of history taking is, first you need to localize which system is involved, whether it is a CNS, central nervous system is involved, or cardiac, CVS is involved, or respiratory system is involved, or GIT is involved, or endocrinology systems. Likewise, so in by history taking, you should have a you would come to a localization. I mean, which system is involved. That is the first thing. Then you need to get the etiological aspect of that problem. Then you need to elicit, are there any complications, or else any associated features are there, or does that problem affects the growth of the child. So likewise, so the history taking involves localizing the problem, where exactly it is, whether it is a cardiac involvement or respiratory system involvement. And second thing, exactly what is the underlying etiology. For example, when it is a cardiac case, so etiological in etiological terms, you need to identify whether it is a congenital or an acquired heart disease. And if it is a congenital, whether it is a left to right shunt or right to left shunt. If it is a left to right shunt, then what could be the probable etiology, whether it is a VSD or PDA or a ASD. So these kind of things you need to get. And then associated complications, like suppose if it is a case of a left to right shunt with large VSD, then probably child could land up in CCF. So you need to know how to take elicit a history of CCF in that particular child. Suppose if you are expecting, if you have concluded that probably it might be a case of left to right shunt with moderate VSD, then the history could be recurrent respiratory tract infections. So like this, so you need to localize the problem, then you need to get the exact underlying etiology. Like in a cardiac case, it is a congenital or acquired. Then if it is a congenital, then whether it is a left to right shunt or right to left shunt. If it is a left to right shunt, then whether it is a VSD or PDA or ASD. Then associated complications you need to ask. So history regarding complications like CCF, recurrent respiratory tract infections, or child's growth might get affected. So you need to ask for history of uh, growth failure, I mean failure to thrive features. Then sometimes a VSD child can land up in having an infective endocarditis. So you need to elicit such kind of history. So localization, exact etiology, what could be the etiology, and then complications or any associated symptoms, and whether this particular problem is affecting the growth and development of the child. So these are the general objectives of a history taking, eliciting a good history. So with this, and then physical examination, you need to confirm what you have got in the history. So if it is a case of suppose cardiomegaly, if it is a cardiac case, then you should look for, are there any features of growth failure, are there any features of congested CCF, then what are the how to what are the findings of cardiomegaly. So these are the terms you need to look when it comes to physical examination. So with this basic background, let's head into a virtual case scenario, and simultaneously we will discuss about the how to examine a cardiac child with cardiac problem. So first thing is, so here we have a virtual case scenario. A 6 months old child by name Charan, resident of Shamirpet, brought by parents and mother being the informant, with chief complaints of fever for 5 days, cough for 3 days, and difficulty breathing or fast breathing for 1 day. So with this chief complaints, I mean fever, a short duration of fever, cough, and fast breathing. That too in chronological order. If you take, a child has developed fever first, and after 2 days of fever, child developed a cough, and after 4 days of fever, child developed fast breathing. So with this chief complaints, what comes to your mind? So one more thing is, at each and every step you need to have build up an idea, I mean idea or some gross diagnosis, not a pinpoint diagnosis. Come to a gross diagnosis, I mean which system with these symptoms you can at least localize, probably which system might have got affected in this particular child. So with fever, cough, and difficulty breathing as a chief complaint, so you might think that, one might think that respiratory system is involved. That is the first possibility, and a remote possibility of cardiac involvement, because most of the times cardiac cases also have a such short history. So so here we should think a respiratory system might have, especially lower respiratory tract might have involved, and a remote possibility of cardiac pathology. So respiratory pathology or else cardiac pathology. So with this chief complaints, then you need to elicit each complaint. You need to elicit each complaint so that you can figure out whether it is a cardiac in origin or respiratory in origin in a history itself. So let's dwell into the history of present illness. So child was apparently well 5 days back, developed fever which is sudden in onset, high grade, continuous, and not associated with the rash, and fever is relieving with medication, that is paracetamol, and cough since 3 days, gradually progressive, wet in nature, no diurnal variation, no aggravating or relieving factors. And child developed fast breathing since 1 day and unable to accept feeds properly. So, with this background, what is your conclusion at the end of history of present illness? So, child is having a fever which was high grade, and followed by a child was having productive cough, that is wet in nature, and then child developed fast breathing. So, with this background, probably child might be having a lower respiratory tract infection from the history of present illness. Then, further dwelling into the history of present illness, we have asked these particular symptoms. So, child was not having any history of cold. Child was not having any history of choking episodes during feeding. So, what is the importance of choking episodes during feeding? So, child who is having swallowing difficulties or can land up in having aspiration pneumonia. So, a preceding history of choking episode followed by child developing fever, cough, and fast breathing, then the possible etiology could be an aspiration pneumonia. So then no history of bluish discoloration of skin. So you need to elicit, one way is whether child is having a cyanotic conjunctivitis. The other way is if it is a severe respiratory illness, then child can land up in having a cyanosis. So that could be a severe respiratory involvement can also lead to a cyanosis. So you need to ask for bluish discoloration of skin, and particularly these two symptoms, that is history of prolonged feeding since birth and history of excessive perspiration during feeding, points more towards a cardiac etiology rather than a respiratory etiology. See, history of prolonged feeding since birth. So, what it tells you, history of prolonged feeding and history of excessive perspiration. an younger infants, like in below 6 months age group, feeding itself is a form of exercise. So when you have cardiac involvement in adults or in older children, you have a exercise intolerance. So here feeding intolerance will be there. So usually child will take a will have a prolonged course of feeding. So for suppose in most of the times infants usually completes their feeding session in most of the times in 30 minutes uh, usually. But if particular child, if a particular child is having a cardiac problem, then his or her feeding session used to get prolonged. I mean, it might take 45 minutes, 1 hour, kind of stuff, and you will have a difficulty in feeding as well. So usually and also you should ask for history of suck rest cycle. Usually infants, what they do is they suck for 3 times. I mean, suck, 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 and then they swallow and they pause, and then again suck, 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 and then they swallow and they pause. So this is the usual course of feeding in a normal infant. When it comes to a cardiac child who is having a cardiac problem, especially left to right hands, they will have a prolonged, I mean, difficulty in feeding. So they suck, they pause, they swallow, they pause, they suck, kind of. So it usually suck, suck, suck. Usually in normal children it used to be suck, 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 swallow and pause, and then suck, 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 swallow and pause, like. But here they suck, they pause, they swallow, they again they pause, they swallow. So usually there will be suppressed cycle. So history of suppressed cycle, and then you usually have feeding difficulties. And one more thing is, obviously, if there is a failure, I mean cardiac failure, your sympathetic nervous system might get activated, and you feel if you observe any adult who is having a cardiac failure, he will be apprehensive, he will be having excessive sweat. So such kind of stuff you can see in infant. You see, especially you see forehead sweating while feeding. So these symptoms, especially prolonged feeding, difficulty in feeding, history of suppressed cycle, history of excessive forehead sweatiness, and these features go in favor of a cardiac rather than a respiratory. This is how, with this history, you can figure out this particular child is having a primary cardiac problem leading to a secondary respiratory problem. If suppose such history is not there, then you could localize it to only, you can limit the problem to respiratory system only. But with these two particular symptoms, I mean history of feeding difficulties, history of excessive perspiration, they give you that child is having exercise intolerance. I mean, a heart is unable to meet the extra effort being taken by the baby for taking feed. So it is not matching up to the increased effort of the baby. So these are the symptoms you can elicit in the history. So with these symptoms you can figure it out to a cardiac problem rather than a respiratory problem. So primary problem is a cardiac problem and secondary problem is a respiratory problem. Then you'll ask for no history of vomiting, diarrhea, no history of cry during maturation. So because this particular child is having fever, and you need to look for other source of infections, like any gastrointestinal system is involved, or urinary tract system is involved. You need to ask, and for that you will ask history of diarrhea or vomiting, history of cry during maturation, and no history of decreased urine output. So this is also an important point in terms of a cardiac problem. So those who are having a severe cardiac failure can end up having a decreased urine output. So you need to give an importance to this particular point as well, particular symptom as well. No history of decreased urine output. And sometimes if the failure is severe, I mean child is having cardiac failure, and you have made it out in the history itself, then you can ask one more history. You can figure out what is if failure is a mild in nature or severe in nature. If it, suppose that the cardiac failure is very severe type, then child might be irritable throughout the day, because cardiac failure relatively causes an hypoxic state, and this hypoxia causes cerebral irritability, and child will be in a state of very irritable state. I mean, child will be crying, irritable throughout the day, and particularly when child was made in a supine position, this irritability gets increased, and when child is made to lie over the shoulder of the mother or father, then child feels really, really bit comfortable. So there is more kind of eliciting a orthopnic dyspnea, orthopnic dyspnea. So that's how you need to test. So those who are having a cardiac failure can have an orthopnic dyspnea in lying down position, orthopnea. So in adults you can ask, if in adults you will ask whether the patient feels discomfortable in lying down position, and patient feeling comfortable in a sitting propped up position, then you can figure out that this particular patient is having orthopnea. But when it comes to young infants, you can ask, and the irritability nature being decreased, child becoming more comfortable in a shoulder rather than shoulder of parents rather than lying down position. So even such history needs to be elicited. So child is irritable in a lying down position, becoming comfortable in a over the shoulder of a parents, then it gives an evidence that child is having a cardiac failure. So this is how you can delineate a cardiac pathology from a respiratory pathology, asking for features of CCF. Then past history. So this particular child is having a similar episode of fever with cough twice 1 month apart in last month. So now the child is 6 months old. So he had particular similar episode at 4 months and then again at 5 months. So it gives you an assumption that child is having a recurrent respiratory tract infection, and especially lower respiratory tract infection. Here, see the significance. Usually, lower respiratory tract infection children only end up in hospital admission. So, for which child was admitted in hospital twice for 1 week duration each time. So, it's a significant illness. So, child had a significant pneumonia and got admitted 2 times in the last 2 months history itself. So, child, by this you can come to a conclusion that child was having a recurrent lower respiratory tract infection, severe lower respiratory tract infection requiring hospital admission. So this will be the usual history mm, in a cardiac case in a childhood, especially left to right shunts with VSDs and PDs. So, and child was diagnosed. So with those previous two illness, and child was diagnosed to be having a congenital heart disease. So what congenital heart disease we don't know, because they don't know. So patients will tell that they they were told child is having a particular, I mean not particular, they have are having a congenital heart disease, and child was kept on. You could see parents will show you the medication they are giving to the child. So this particular child is on furosemide drops daily, and parents discontinued this particular medication since 2 weeks. So so let's summarize the history of paternal illness. So this particular child is 6 months old, who had a recurrent lower respiratory tract infection. So I mean recurrent in the sense he had 2 episodes of lower respiratory tract infections requiring hospital admission. So it's a significant illness requiring hospital admission for 1 week, and again at present again he had a similar presentation, but this time this child is having is breathless, I mean is having fast breathing as well, and history also suggests of congestive cardiac failure. So you have feeding intolerance. So feeding intolerance, excessive perspiration while feeding goes in favor of a cardiac failure. So recurrent lower respiratory tract infection with CCF. So and child was diagnosed having a congenital heart disease and was on furosemide drops. So furosemide drops, if child is receiving furosemide drops, then it indirectly also tells you that child is having a CCF entity. So with this background, you can localize the system, which system is involved. So this child is having a cardiac pathology, and taking into the age. So this child has a history from 4 months onwards. So it goes more in favor of in favor of congenital cause rather than acquired cause. Usually acquired causes which has got a chronic in nature, they usually present later part of life. I mean, in suppose if you consider acute rheumatic fever, so the common age group of presentation is 5 to 15 years age group. So in most of the times congenital heart disease presents in first year itself. um, so in first year itself. So age of presentation will lead you to whether it is a congenital and acquired diabetes. So here a 6 months child with the past history right from 4 months of age, so goes in favor of a congenital maca. So cardiac, congenital, then comes whether it is a left to right shunt or right to left shunt. So here the problem is recurrent LRTI, CCF goes more in favor of left to right shunt rather than right to left shunt. So usually left to right shunt will have such history, recurrent LRTIs and CCF kind of stuff. Whereas right to left shunts like a TOF, tetralogy of Fallot, usually have cyanotic spells history, bluish discolorization, such kind of history rather than pneumonias and CCF. So pneumonia, recurrent pneumonia and CCF goes in favor of left to right shunt. Then what could be the possible etiology, whether it is a VSD, PDA or else ASD. So these are all the three left to right shunts we all know. ASD will have a presentation in later part of life. Usually child will have symptoms at 4 to 5 years of age and can land in a state of frank failure in 20 to 30 years of age. So then comes, so ASD can be ruled out. Then what it could be, VSD or PDA. So then, so yes, it could be either a VSD or PDA. But in terms of, you need to look at the birth history. Suppose if it is a term child, then probably child might be having a VSD. If it is a preterm child, probably child can have a PDA. And PDA usually presents at early point of time. I mean, they present at 1 month, 1.5 month, not at 4 months kind of stuff. So so from such history we can come to a gross diagnosis, thus that child is having a cardiac problem, a congenital cardiac problem, which is left to right in nature, and probably VSD, and you can describe the severity of VSD in history itself. Suppose if suppose from this history we could able to figure out that this child is having a congenital cardiac problem which is left to right in shunt and probably VSD. And you can also figure out whether it is a mild, moderate or severe in nature. I mean severe VSD or a moderate VSD or mild VSD, that also you can figure out from history itself. So mild VSDs most of the times will be asymptomatic. So child comes to clinic for some other problem and you auscultate and you will find a murmur and then you investigate and then you will come to a diagnosis that a mild VSD. And so most of the times a mild VSDs are asymptomatic. And then comes moderate VSDs. So moderate VSDs usually have a recurrent pneumonia history and very unusual to have a cardiac failure history. So moderate VSD. Then when it is a case of severe VSD, so child can have recurrent lower respiratory tract infections with the CCF kind of history, congestive cardiac failure history. So here child is having recurrent pneumonias, CCF history, so probably a severe VSD. So severe VSD. So this child might be having a congenital cardiac problem, which is congenital in nature, which is a left to right shunt, and probably VSD. And VSD that too could be severe VSD because this child is having pneumonia as well as CCF. So that's how you need to conclude at the end of history of present illness and past history together. So, with this history, we have come to a conclusion that this child might be having a cardiac problem, which is congenital in nature, which is left to right in shunt in nature, and probably VSD, and probably severe VSD, and this child is also having a features of CCF. CCF. And in history itself also you should ask for history suggest of infective endocarditis. So when you suspect infective endocarditis, obviously VSDs, PDS, they are prone for developing infective endocarditis. So how to get elicit the infective endocarditis history? So the norm is any predisposed congenital cardiac disease with history of high fevers for one week, then it obvious and then it could be infective endocarditis unless otherwise proved. So you should ask any history of arthritis. So usually infective I mean joint pains. So usually infective endocarditis. So it is, although it is quite unusual, a 6 months old child telling not possible telling a joint pains, but mother can figure out that whenever child is made to sit, I mean, or made to lie down, so child becoming more irritable, touching joints, then child becomes more irritable, tender joints. So you need to have such history. So child becoming more discomfortable while moving, becoming more discomfortable while moving the child, or any tender joints, I mean the red joints, and then having a high grade fever for more than 1 week, having hematuria. Usually infective endocarditis children can have a hematuria. So you should ask cola colored urine. So you need to ask for color of the urine as well. So with any rashes over the body, so with such history you can rule out a possibility of infective endocarditis. So here a short history, I mean only 5 days of history of fever. So you can rule out a possibility of infective endocarditis, and even you can look for signs of infective endocarditis when you are examining the child. So from history it is unlikely child is having an infective endocarditis. So that's how you need to draw assumptions from your history. Then, so these are the usual scenarios of a cardiac pathology in children having cardiac pathology. So child can have a breathless, I mean fast breathing. Breathlessness is more a subjective feeling. So those who are suffering can able to tell that they are breathless, but when it comes to pediatric age group they can't reveal you. So mother will figure out that child is having fast breathing or difficulty in breathing. So that is the so don't say breathlessness or shortness of breath as a chief complaint when it comes to pediatric patients. So you tell fast breathing because it is a subjective observation. I mean, mother observes the child, because child 6 months child won't complain that child, I am having breathless, I am having breathing difficulty. It's the mother who observes and tells you the history that child is having fast breathing or child is having difficulty in breathing. And the second thing, mother finds it difficulty in feeding the child. So obviously those who are having a recurrent respiratory tract infections, those who are having CCF will end up having protein energy malnutrition, that is failure to thrive. Because on one side, because of feeding difficulty, they tend to take a low calories, I mean their capacity of I mean eating capacity comes down. On another side, more calories are being burnt because congestive cardiac failure is a high metabolic state. So more and more calories are being utilized. So uh, demand is high, but the supply is also poor. So these together child can land up having failure to thrive. So sometimes the presentation could be mothers will come to clinic with complaints of a child is not putting on weight when compared to the peers. I mean, fellow children of same age group, mother has observed that particular child is not putting on weight. So, one possible manifestation could be failure to thrive. So all the children who who comes to the clinic, mother complaining that child is not putting on weight when compared to peers, then you should have a cardiac etiology as your one of your differential diagnoses. Sorry. And one more kind of presentation is cyanotic spells, and cyanotic spells are usually seen in right to left shunts, particularly TOF. So you need to know how to elicit cyanotic spells history. So a child will be relatively in a bluish discolored state. When he becomes irritable, this bluishness increases, and and this bluishness will gets on increases will get on increase, and at the same time child might become unconsciousness and might develop seizures. So these the how the cyanotic spells history will be there, and you need to differentiate it from the breath holding spells. And then likewise in our child, I mean the 6 months child, Charan has got a recurrent lower respiratory tract infection. So broadly these could be the possible presentations of a cardiac patient: breathless, fast breathing, poor feeding, failure to thrive, cyanotic spells, recurrent lower respiratory tract infection. So in broader sense these are the possible presentation scenarios. in a cardiac child. Then you should ask other history as well. So you have come to a conclusion that child was having a cardiac etiology, congenital in nature, a left to right shunt, VSD, severe in nature. So now what made this child having a VSD? So not all children will have VSD, only particular children. Then there will could be a possible etiology, although it is not possible to get a what could be the particular etiology, but we need to elicit from family history, antenatal history. Suppose if mother has exposed to any teratogenic drugs, and these teratogenic drugs can lead to a VSD in will impair the cardiac development in the fetus, and thereby can child can land up in having a BSD. So you need to elicit the history. Suppose here the family history says that mother age is 21 years. So what is the importance of mother's age and father's age? So those who are having, I mean, above 35 years age group. So these particular parents, those who are having advanced age, I mean 35 years, both and mother father are above 35 years age group. Then this particular couple are at risk of having a child who is Down syndrome, Down syndrome. And Down syndrome, particularly Down syndrome children are the cardiac complication is endocardial function defects and BSDs. So these particular children can have. So that is the importance of mother's age. So look at mother's age, whether they are of an advanced age or, uh, uh, or in a normal, age group if they have got married. So it is 21 years, 21. So you can rule out the possibility of Down syndrome here. I mean, in a broader sense. Then non-consanguineous marriage. Though non-consanguineous marriage doesn't carry any suggestion. So I think there are few congenital heart diseases which are autosomal recessive in nature. Ellis van Creveld syndrome. So these are autosomal recessive in nature. So consanguineous history hardly provides you any information. And then 2 years of marital life that doesn't carry any significant evidence. And then no history of cardiac problems in the family. So this particular history, suppose mother is having a VSD, then child can have six, there are 6% of chances that child can have VSD. If father is having, then the 2% chances that child can have a VSD. So likewise, so no history of any cardiac problems in the family. So that you should ask, particularly congenital cardiac problems in the family. And then antenatal history. What is the importance of antenatal history? So primary mother here, regular antenatal checkups, received iron folic acid and received 2 doses of TT. And you should ask for any teratogenic drug intake. Suppose a mother is a known case of epileptic disorder, and mother takes any anti-epileptic medications, especially sodium valproate, and she doesn't know that she has conceived, and mother continued taking anti-epileptics in first trimester, especially valproate. And this valproate and phenytoin can lead to a particular cardiac defect in the child, especially VSDs, coarctation of aorta, such kind of diseases in the fetus. So you need to ask for particular any history of teratogenic drug or any radiation exposure. Such kind of stuff you need to ask in antenatal history. So then birth history, coming to importance of birth history. Male child, term gestation, normal delivery, cried immediately of birth with the weight of 2.6 kg and no history of any NICU admission. So term gestation or preterm gestation. So preterm gestation, we all know that preterms are at risk of having a PDA, patent ductal arteriosus. So you need to see term gestation, and you need to see the weight of the child is 2.6 kg. So and child falls in a category of appropriately gestational age. So he is having appropriate age for that particular gestational age. Sometimes child can have a babies will be large for gestational age. So they tend to wait more for that particular gestation. Suppose a child weighing 4 kgs, then these particular children will have a particular association, cardiac associations, like a large for gestational age babies might have end up having transposition of great arteries, TGS. So birth weight. Birth weight also carries a significant importance in cardiac patients, pediatric cardiac children having cardiac problems. So low birth weight preterms, they are at risk of having PDA. LGA babies, they are at risk of having a TGA, transposition of great arteries. So important, that is the importance of birth weight. Then this particular child was breastfed shortly after birth, and child is on exclusive breastfeed. And you need to elicit the feeding history as well. So here the history of present illness is suggestive of feed intolerance. So you need to ask, when did the child mother started observing feeding intolerance. So usually a congenital child having an infant having congenital heart disease, particularly left to right shunt, will have feeding difficulties from 6 weeks onwards. 6 weeks onwards. So in feeding history, you need to elicit such history. So when mother has started observing feeding difficulties in the particular child, usually it will be at 6 weeks of age, where your pulmonary vascular resistance will come down, and this left to right shunt will get increased, and there will be increased congestion in the lungs, and increased return to the left heart, and there will be overload of the left heart, and this could lead to CCF. So you need to ask for history of feeding difficulty, what point of time mother has observed, usually at 6 weeks of age. And then developmental history. So though this particular child is not having any CNS problem per se, failure to thrive itself can lead to delayed milestones. I mean, there will be mild to moderate delay in the development history. But here, the child was not having any development delay. So here, the child has achieved milestones as per age. So this could be a possibility. So child can have milestones, but when it is a severe illness requiring recurrent hospital admissions, having a significant PM component, so these children tend to have a mild to moderate developmental delay. Then immunization history. So the what is the importance of immunization history in a cardiac children? So by history of present, I again gone to repeat again what we have concluded at the end of history of present illness, because I want to carry that by the end of history of present illness itself, you can come to a diagnosis. So that's what I am trying to give you. uh, that's why I'm repeating again and again that we have come to a conclusion that this child is having a cardiac problem, congenital left to right shunt, VSD severe with CCF. So I will go on to repeat these words throughout the presentation, because I want to carry a point that you can figure out the problem in the history itself, if you elicit a good history. So with our history of present illness, we came to conclusion that this particular child is having a cardiac problem, which is congenital in nature, which is a left to right shunt, which is probably VSD, and probably severe kind of severe VSD, and with CCF. So what is the significance of immunization history in in this particular age? In general, immunization is good for children. So you need to elicit immunization history in every pediatric age group. But when it comes to cardiac case, what is the importance of immunization history? So this child is having recurrent respiratory tract infections. So in general, cardiac patient itself, I mean, especially left to right shunts with VSDs, PDA, they are predisposed to pneumonias, recurrent pneumonias. So what you want to do, you want to prevent pneumonia from a common causative organism by doing vaccinations. So you need to ask whether this child has received pneumococcal conjugate vaccine or not. So the IAP vaccination schedule says the all children has to be vaccinated against pneumococcal at 6 weeks, 10 weeks, 14 weeks vaccination schedule. So this child is 6 months old, then you need to ask for a history whether child has received pneumococcal conjugate vaccine at 6 weeks, 10 weeks, and 14 weeks. So you need to ask, and 6 months, being 6 months old, you need to ask her whether child has received any influenza vaccine. So if a child takes influenza vaccine, pneumococcal vaccine, then less likely chances this particular child can develop pneumonia, and this helps a lot when it comes to a cardiac patient. So You ask the history of whether the child has taken pneumococcal conjugate vaccine or influenza vaccine. If no such history is there, then advise the parents to get the child vaccinated against these especially pneumococcus and influenza vaccine once child is stable. Then socioeconomic status belongs to lower socioeconomic status. So this carries importance when it comes to treatment. Then so 6 months of child, what developmental milestones would you expect in this child? And tell the vaccination schedule of this. These are the usual questions that you will be asked, during your presentations. So that completes our history. So, and make a habit that conclude your findings, I mean conclude your history findings at the end of history, summarize the history at end of your history taking. So let's summarize. So before going on to the examination aspect, let's summarize the history. So here is a 6 months old male child by name Charan with history of recurrent respiratory tract infections at one at 4 months of life and one at 5 months of life, a significant respiratory tract infections requiring hospital admission for 1 week, and again now presented with a short history of 5 days history of fever, 3 days history of cough, 1 day history of fast breathing, and history suggestive of feeding difficulties, history suggestive of excessive perspiration, which indirectly suggests of a congestive cardiac failure. So that's how you need to summarize the things at the end of the history. So with this history, so we have come to a conclusion. Again, I will repeat. So by history itself, we came to a conclusion that there is a cardiac problem, there is a congenital problem, there is a left to right shunt problem, there is a VSD, probably a VSD, there is a severe VSD, severe in nature. Then nature of illness is severe. I mean severe VSD, and then you could figure out the child is having CCF features as well with history of recurrent respiratory tract infection. So with this history, let's look into the child. Let's observe the child. Let's examine the child. So first thing is coming to the physical examination, general examination aspect. See the child in total. How is the child? He is comfortable in mother's position, or he is tachypnic. I mean, he is finding it difficult to, he is discomfortable at roommate. So such kind of stuff. Whether he is active, dull, or is apprehensive, or is comfortable in mother's lap. So that is the gross, I mean gross description. That is the gross description of the child. Then you go on to take anthropometry and vitals. So it has to be vitals first, later on the anthropometry. So vitals here, the pulse is 120 per minute, regular, high volume, regular, no radio radial or no radio ephemeral delay. So that is how we need to describe the pulse. So we need to describe the rate, the rhythm, volume, any special character is there, and whether there is a radio radial or radio femoral delay. So 120 per minute in this particular child, 6 month child, is not too high, but here the volume is high. So because large VSDs, I mean with this cardiac problem, child is a high output state. So usually these children will have a high volume high volume pulse. So here we got and heart rate also should be on higher side rather than normal side. And then look at the rate, respiratory rate, it is a 56 per minute. So child is quite tachypnic. So although here just pulse has been mentioned, respiratory rate has been mentioned 56 per minute, while presenting the case to the examiner, don't say just a respiratory rate is 56 per minute, and you draw the conclusion. I mean respiratory rate 56 per minute and it's tachypnic, child is tachypnic. So that's how you need to say. Don't say just a respiratory rate 56 per minute. Don't just go on to tell the findings like respiratory rate 56 per minute, BP is 90 by 50, temperature is 101 degree Fahrenheit. So conclude your findings. So here pulse is high volume, respiratory rate is 50, 56 per minute. That means the child is tachypneic, and then blood pressure is 90 by 50 is okay. Then temperature 101 is febrile. So child here from vitals we have concluded that child is febrile, and child is having a high volume pulse, and child is tachypneic. That's how that are the findings of vitals. Then comes to anthropometry, weight for age. So a 6 months child weighing 4.5 kg is way too low. Usually a well-fed child, a 6 kg child with a birth weight of 2.5 kg and normal birth weight, then they tend to have weigh around at least 6 kg, 7 kg or 8 kg. uh, mm, But here child is weighing 4.5 kg, and you need to plot it on the centile charts, growth centile charts. So when this particular child has been plotted on the centile charts and it comes to less than first centile, so here child is having a significant growth retardation, and especially in weight, in terms of weight, but length is spurred. So length is 64 centimeters, and child lands in between third to 50th centile. So length is related to spurred, weight is affected. Then head circumference is also fine. So what is your inference based on that, based on anthropometry? So a 6 months child weighing 4.5 kg, so he is having significant protein energy malnutrition. So based on pm malnutrition, you need to grade the child. So weight of the child by expected weight for that age into 100. So if it falls more than 80%, then it is normal. 70 to 80, grade 1. 60 to 70, grade 2. uh, 50 to 60, grade 3. Below 50, then grade 4, protein energy malnutrition. That's how you need to figure out. So you need to grade the child in terms of protein energy malnutrition. So here from anthropometry, weight is only affected if it is a long-standing problem. So if child has been diagnosed with 6 months of life and you have started intervention, then child recovers. I mean, once you start treating the child, child can achieve a normal growth. Suppose the child has been neglected, if child remains undiagnosed, child goes on to suffer from this problem time and again. And mortality is one other aspect. The other aspect is child, then not just weight, even length is going to get affected. So child can become stunted. So that's also chronic cardiac problem can also lead to a stunted child. So his stature might get affected. He might become short statured as well if it is a child remains undiagnosed, is having such history, and he is going to suffer for a prolonged period and doesn't provided any interventions. Then child length also gets affected. So anthropometry vitals. Then these are the terms by which pulse has to be described: rate, rhythm, volume, character, radial delay, radiofemoral delay. So rate, with rate you can conclude the child is tachycardic or bradycardic. You need to have. And then rhythm, whether it is a regular in rhythm or irregularly regular or irregularly irregular, such kind of thing you can describe in the rhythm. And volume, whether it is high volume pulse or a low volume pulse. High volume pulse means high output state, low volume pulse means this could be a severe CCF feature. So CCF in initial stages can have a high volume pulse, and if CCF is severe in nature and is collapsing, then child can have a low volume pulse. And character of pulse also you should describe. So you have different characters like collapsing pulse, water hammer pulse, pulses bisference, pulses bigeminy. So this kind of, so you need to tell what are the differential diagnosis in such a slow rising pulse, such kind of characters. You have different characters of pulse. So for the particular character of pulse, you can uh, uh, figure it out a particular cardiac problem. And radial delay and radiofemoral delay. So you see radial delay in a case of preductal coarctation of aorta. Radiofemoral delay you could see in a postductal coarctation of aorta. So basically you need to palpate palpate for all the pulses. And particularly if you see radiofemoral delay, so what exactly means radiofemoral delay? In a normal scenario, you feel femoral pulses ahead of radial pulses. So those children having a coarctation of aorta, this gets altered. So here you will see a radial pulse being felt ahead of a femoral pulse. Normally femoral pulses are felt ahead of radial pulses, but when it comes to a coarctation of aorta child, so radial femoral pulse might be presented at the same point of time, or radial pulse ahead of a femoral pulse. That is the significance of radiofemoral delay. Then blood pressure. So while taking blood pressure, these are the things you need to describe. Appropriate, whether you have taken it with an appropriate size cup, whether you have taken a sitting or supine position, and then you need to take the blood pressure in lower legs as well. So normally the gradient between the upper arms and arms and legs are usually 10 mm of Hg. So if this gradient becomes, so usually legs will have a higher blood pressure, because what could be the reason? So you measure the lower limb blood pressure with the same cup that is intended for the arm. Generally, the cups are made keeping in mind that arm blood pressure is being taken. So we use the same cup for the lower, legs as well. That's why you end up having a 10 mm of Hg higher blood pressure in lower limbs when compared to upper limbs. That is the reason. But this gradient has become reversed. I mean, if you observe that observe that child is having a higher upper limb blood pressure when compared to lower limb blood pressure, then possibly coarctation of aorta could be a possibility. Huh? So that's all. And then the other thing is you need to plot the blood pressure on the charts. I mean, you look at the charts and then you label if child is having a normal blood pressure, or in a state of pre-hypertension, or grade 1 hypertension, or grade 2 hypertension, or hypertensive emergency, such kind of scenarios by looking at the charts. So one thing, while looking at chart, you should know the height of the child as well. Then JVP. So you have usually below 3 years age group, we don't observe JVP because of short neck. But when it comes to above 3 years age group, you can observe JVP. So how to examine JVP, jugular venous pulse? So you place the patient in a supine position initially to engorge jugular veins, and then gradually raise the head of bed until jugular venous pulsations become evident between angle of jaw and clavicle. So you make the child in a lying down. So it's quite difficult to observe JVP in this particular age group because of short neck. So JVP becomes obsolete. Doesn't carry any significance because you can't observe in a below 3 years age group. So from above 3 years age group, you need to describe JVP. So you need to know how to measure JVP, and then what are the cause of raised JVP. And then head to toe examination. So head to toe examination, child is quiet in mother's lap, not interested in surroundings, lethargic, no facial dysformism. So you need to look for dysformic features in the face. Downs, are there any features of Turner syndrome, are there any features of Williams syndrome? Suppose if child is having any midline defects, especially cleft lip or cleft palate, then these children are at risk of having cardiac problems, vice versa. So that's how you need to look for any uh, 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 facial dysmorphisms as well. Then look for pallor. What is the importance of pallor? So from history, we have concluded that child is having congestive cardiac failure because of left to right shunt. There is a overload on the heart, and added on that, if child is in a state of anemic state, and it it makes heart more vulnerable. I mean, the stress on the heart is increased. So on one side, child is having a left to right shunt, and this has led to a overload on heart. And child having anemia it further worsens the condition. So pallor in a congestive cardiac child, so a moderate CCF can go into a state of severe CCF. Child is having pallor. So pallor adds, I mean anemia adds extra stress on the failing heart. So especially 6 months old child, this is the time for starting complementary feeding. So if you don't start a appropriate complementary feeds, then child can have a pallor because of I mean nutritional anemia. So you need to look for any evidence of pallor. Then you look for no cyanosis, no clubbing, and no pedal or sacral edema. So no cyanosis. Cyanosis per se indicates mostly a right to left shunt. Here, from history, we have concluded that this child is having a left to right shunt. So obviously, there won't be any cyanosis in this child. But later on in life, a child who is having a left to right shunt later on in life can develop cyanosis. So, what could be the possible possible mechanism under the possible underlying mechanism? So a child who is having a left to right shunt for a prolonged period can have a pulmonary arterial hypertension. So this pulmonary arterial hypertension becomes initially it becomes hyperdynamic pulmonary arterial hypertension because of excessive blood flow to the pulmonary arteries. So once this excessive blood flow to the pulmonary arteries is there for a prolonged period, then these pulmonary arteries will get into a constricted state, and this lead to obstructive pulmonary arterial hypertension. So this child, a left to right shunt child becomes a right to left right shunt, left to I mean right to left shunt. So initially it is a left to right shunt. So excessive blood will be going into the pulmonary arteries, and these pulmonary arteries exposed, chronically exposed to high volume of blood, they get constricted, and this constriction leads to elevated pressures in the pulmonary artery, that is pulmonary arterial hypertension. This elevated pulmonary hypertension can make the shunt reversal of shunt. So a left to right shunt becomes a right to left shunt, and this child can have a cyanosis. So this is an Eisenmenger phenomenon. So possibility. So yes, there is a possibility that left to right shunt children can have cyanosis at later part of life. And then clubbing. Clubbing usually seen in cyanotic congenital heart disease, but yes, you can see clubbing in a case of a cyanotic congenital heart disease also, especially child is having a infective endocarditis, subacute infective endocarditis. So VSD is predisposed to infective endocarditis. So if it is a subacute endocarditis, then child can have a clubbing. Then you need to look for a dependent edema, especially children having cardiac failure can have a dependent edema, and those who are ambulatory about 2 years age group, 3 years age group, they can have edema at, on foot. But most of the times in a below 2 years age group, they lie in a supine position. So the dependent edema is in buttocks or in sacrums or in nape of the neck. So these are the areas you need to look for the dependent edema. So so that is the importance for examining facial dysmorphism, facial features, look for evidence of any pallor. So pallor per se doesn't give you any I mean importance in diagnosing the child, but it gives you that suppose if child is having pallor, then his cardiac failure gets worsened. So you need to manage the pallor aspect, I mean anemia aspect as well. So cyanosis, yes, cyanosis can sometimes can add to your diagnosis and can give you information about any associated complications like left to right shunt becoming a right to left shunt. And clubbing per se can lead to whether it is a congenital cyanotic in nature, or else child might be having a subacute infective endocarditis and edema CCF. So what are the things you want to look for, then so you have taken anthropometry, you have looked at vitals, and you have done head to toe examination, and then you need to look for signs of infective endocarditis and signs of congestive heart failure. So what are the signs of infective endocarditis? So these are the signs of infective endocarditis. So fever with chills, children with a left to right shunt having fever with chills, tachycardia, osseous nodules, Janeway lesions, arthritis, splenomegaly, clubbing, petechiae, splinter hemorrhages. So these are the signs of infective endocarditis. You need to look for the signs of infective endocarditis, and you should say no signs suggestive of infective endocarditis. So here the child is not having any signs of infective endocarditis. Then what are the signs of congestive heart failure? So signs of congestive heart failure is tender hepatomegaly, basal crepitations, edema in dependent region. So in infants it is sacrum, in older children and pedal edema, and in older children you can see elevated GFP. So these are the signs of congestive cardiac failure. Then likewise we have discussed the facial features. So you should look for syndromic features. So Down syndrome. So Down syndrome associations are endocardial diffusion defects and VSDs. Not all Down syndrome will have endocardial defects and VSDs, but majority of Down syndrome children will have ESDs and VSDs, and congenital rubella syndrome associated with PDA and Turner's coarctation of hydra. So syndromic features you need to see, and then signs of rheumatic fever, acute rheumatic fever. The signs of acute rheumatic fever are arthritis, subcutaneous nodules, scoria, erythema, and marginal. But one thing, only in above 5 years age group only you should look for, or you should mention signs of rheumatic fever. Here the child is 6 months old child and addressing signs of there are no signs of acute rheumatic fever in this child, then it's an absolute blunder. So a 6 month child usually don't have an acute rheumatic fever. So acute rheumatic fever, the age group is 5 to 15 years age group, so don't mention signs of rheumatic. There are no signs, though there are no signs, you don't mention no signs of acute rheumatic fever. Don't tell the history of a rheumatic fever signs, or else history suggests of rheumatic fever or signs suggest of rheumatic fever. You should not use these terms if it is a below 5 years age group. So unlike a below 5 years child having a rheumatic fever history. But remember that these are the signs of rheumatic fever. Suppose if you come across a child 5 years age group and you are suspecting a cardiac problem, and the first possibility could be a rheumatic fever, acute rheumatic fever, then you should know how to elicit acute rheumatic fever history, how to look for what are the signs of acute rheumatic fever. You should know. That's how I have mentioned in this slide, but it is nowhere related to our case, because here the child is 6 months old child and asking for looking for signs of a rheumatic fever, or asking for signs of history of a rheumatic fever is a blunder. Then coming to systemic examination. So from history we have concluded that is a cardiac case. So obviously we'll start with examine cardiovascular system first and later on respiratory system. So here cardiovascular system. So it starts with inspection. So inspection you need to see the shape of the chest. So whether it is a bilateral symmetrical, is there any precordial bulge, is there trachea, then position of trachea. So what is the importance of tracheal position here? So here child is not having any precordial bulge, and then apical impulse is visible at fourth intercostal space lateral to mid-clavicular line. So in fact it has to be sixth intercostal space, lateral to mid-clavicular line. No visible pulsations, no engorged neck veins. So what is the importance of tracheal position? So you are looking at the cardiovascular system, and then why you need to talk about the tracheal position. So the importance of tracheal position is, so if apical impulse is shifted to outwards downwards, then possibly cardiomegaly can be there. The other possibility is mediastinal shift. So whenever the mediastinum has been shifted towards left side, obviously the apical impulse also will get shifted, but doesn't mean that child is having cardiomegaly. So how to figure it out? The shift in cardiac impulse is whether it is basically because of cardiomegaly or else because of mediastinal shift. So you need to look at the trachea. So if trachea appears in normal position with the apical impulse shifted downwards and outwards, then the reason for shifting of apical impulse could be cardiomegaly. If suppose even tracheal position has been shifted towards the left side with the apex being shifted to outwards and lateral, then possibly mediastinal shift could be the reason. So you need to figure out by looking at the tracheal position whether the shifted apical impulse is basically because of cardiomegaly or else because of mediastinal shift. So that's how. Then any visible precordial bulge, so you need to look for precordial bulge. So children having right ventricular hypertrophy can have a precordial bulge. Then any visible pulsation, so children having hyperdynamic heart or else suppose hyperdynamic heart, especially those who are having in a frank failure state can have a hyperdynamic multiple pulsations will be seen. It is hard to figure out apical impulse in such children because there will be multiple pulsations throughout the precordium. So you need to look for pulsations at sternum as well. I mean, uh, uh, then suprasternum as well. Then at xiphisternum, you need to look for the pulsations. Are there any engorged neck veins? So what are the conditions where you see engorged neck veins? When you have superior vena cava obstruction. So when you have superior vena cava obstruction, obviously any thoracic mass in thorax, it might compress the superior vena cava, especially malignancies like lymphomas. Such kind of stuff can compress your superior vena cava, and this children can have engorged veins. So looking for pulsations, engorged neck veins, and position of apical impulse, position of trachea, precordial bulge. So that's how you can. So you from inspection, what are all the things you can figure out whether what is the position of apical impulse, and if apical impulse has been shifted, you can figure it out whether it is a because of cardiomegaly or mediastinal shift. Then you can figure it out by looking for visible pulsations. So if child is having a multiple pulsations on precordium, then hyperdynamic heart. If child is having xiphisternal pulsations, then right ventricular hypertrophy is there. So such kind of shift. So if there are any engorged neck veins, the possibility of superior vena cava obstruction should be considered. And then look for scars. Suppose if child has undergone any open heart surgeries like thoracotomy, then you could see the scars. So you need to look for the scars, any surgical scars. Then coming to palpation. So in palpation, you will confirm all the expected findings. So apical, so the same tracheal position you will confirm. How do you look? You palpate. I mean, a tracheal position in palpation. How do you do tracheal position in palpation? So you need to keep your index finger and your ring finger over the sternal clavicular end of the sternum. I mean, sternal end of the clavicles, and you need to run the middle finger over the neck. So by that you can make out whether trachea has been shifted to right side or left side. So it's likewise apical impulse has to be felt. And one more thing is you can look for the nature of apical impulse. So what is apical impulse and what are the different apical impulses, you know? So there are different apical impulses. So the apical impulse is the outermost lowermost cardiac impulse you get, then you label it as an apical impulse. The impulse is nothing but of a left ventricular in origin, and different types of apical impulses are hyperdynamic, heaving, hyperdynamic when there is a volume overload, heaving when there is a pressure overload, and retractile. Suppose if there is a right ventricular enlargement, especially you come across TOF, then obviously your left ventricle goes behind, and because of this, the impulse can become retractile. Then rather than impulse to your hand, the impulse you could feel that impulse is getting inwards. I mean drawing inwards. That is retractile. So retractile apical impulse, hyperdynamic apical impulse, heaving apical impulse. So these are the different or tapping. So whenever left ventricle receives less blood, then usually the apical impulse will be tapping in nature, and you come across in mitral stenosis. So here the apical impulse is hyperdynamic in nature. Apical pulse is shifted to 16 intercostal space to lateral to cardiac mid-clavicular line. So here child is having cardiomegaly as well. Then um, after palpation, you need to do percussion. So percussion has to be done after auscultation only, because percussion carries some sort of discomfort to the baby. Though while presenting the case, you present percussion ahead of auscultation, but when it comes to examining the child, you auscultate first and then percussion has to be done last, because percussion carries a little significance, and percussion can disturb the child, and thereby it hampers your examination further. So that's why percussion has to be done at last. But while presenting the case to the examiner, it has to be the percussion ahead of auscultation. So percussion, what is the importance of percussion? So you percuss basically to figure out the cardiac borders. So where is exactly left cardiac border, where exactly the right cardiac border. So figure out to figure out cardiac borders, you percuss. And one more important thing is percussing the left second intercostal space, medial to mid clavicular line. Because that is where the main pulmonary artery lies. And whenever child is having a pulmonary arterial hypertension, usually the note will be resonant there. But when there is pulmonary artery enlargement and blood flowing through it, the resonant node becomes dull. So, left second intercostal space midclavicular line becoming a resonant node becoming dull, then it's an indirect evidence that child is having pulmonary arterial hypertension, significant pulmonary arterial hypertension. So that's how you can, that is the importance of percussion. Basically, for looking for borders of heart, looking for dull note in second intercostal space, usually resonant. But if child is having, this particular child can have a dull note if the shunt is significant and child is having a primary arterial hypertension as well. So then auscultation. So auscultation, here the first heart sound is not heard and second heart sound is heard, and grade 3 pansystolic murmur in left sternal edge without radiation, and there are no added sound. So here the first heart sound is muffled. It is muffled with the pansystolic murmur. So pansystolic murmur means it starts at H1 and it almost ends at the H2. So the murmur runs throughout the systole. So that's how you label it as pansystole murmur. So it is masking the first heart sound. Yeah, and look at the nature of the second heart sound. So nature of second heart sound. If second heart sound usually have a split in a inspiration, during inspiration. So variable split is a nature. So usually you will see a A2 component ahead of a P2 component. So if such is the scenario, it's okay. If there is no split and second heart sound becoming loud, then in this particular child, then child might be having a pulmonary arterial hypertension. So here is the case. So here is having a second heart sound, single second heart sound which is loud, then it infers that child is having a pulmonary arterial hypertension. And look at the grade 3 pansystolic murmur left sternal edge without radiation. So this is the pathognomic finding in a case of BSD. So from history itself, we have concluded the child might be having a BSD. So here, even our auscultative findings is suggestive. So the other possibility we thought in history is PDA, possibility of PDA. But PDA will have a continuous murmur and usually seen in the left second intercostal space. But here in pulmonary area rather than in left sternal edge. So here the child is having a grade 3 pansystole murmur in the sternal edge. So you need to describe the murmur in 8 terms. So whether it is a systole or diastole, grading of murmur, variation with respiration, and variation with the position of the child, any radiation is there. So you need to describe a murmur in different terms. So systole or diastole, grading, kind of stuff. So here grade 3. So grade 3, usually grade 4s are associated with thrills. So here you might think that in history we have concluded that the child is having a severe CCF, but here we are saying that murmur is grade 3, not grade. So usually what we think that if the nature of the I mean shunt is severe, you have a higher grade of murmur, but that is not the thing. So when you have severe nature, the intensity of murmur will come down. So a narrow hole makes a loud noise. When the hole is large, noise becomes low. So that's the reason. If you have a large VSD, then don't expect a child might have a higher grade of murmur. That is not the case. Child will have a lower grade murmur, I mean grade 2 grade 3 murmur. Suppose if child is having a mild VSD, then he can have a grade 5 murmur, grade 6 murmur. So narrow the defect, louder the murmur. Larger the defect, less is the murmur. So that's how. So here the defect is being large, there won't be any significant, I mean higher grade murmur. So that's why you don't see any thrill. So that's why this child is having, though he is having a large VSD, severe VSD, but the murmur is low grade murmur, I mean grade 3. Then you look for respiratory system. So here the secondary pathology lies in the respiratory system. So you see nasal flaring, tracheal position, so all the things you will see. Only thing is, only importance is here is you need to look for the basal crepitation. So basal crepitations, if there are any basal crepitations, then it could be a CCF as well. And here rest of the lungs are normal. So probably here child is having a CCF. And then other systems you need to look for CNS, and here no abnormality has been detected. So let's summarize the case. A 6 months old child, Charan, first born to a non-consanguineous couple with history of recurrent respiratory tract infections, not gaining adequate weight, presented with fever since 5 days, cough since 3 days, difficulty in breathing since day 1 day, with normal birth and development history, with the history of prolonged feeding and excessive perspiration. An examination, child has mild pallor, nasal flaring with the traction of chest wall, and with the grade 3 PSM, with the apex being shifted outwards, with crepitations over lung field. So this is the case summary. So what is your conclusion of this summary? What is your provisional diagnosis of this? So you need to describe. So whether it is a congenital heart disease. So by age itself, you can conclude that this child is having onset of symptoms right from 4 months of age. So possibly congenital heart disease. Then whether it is a left to right shunt or right to left shunt. So no cyanosis, no bluish discoloration history, or no cyanosis in the physical examination. So you can rule out right to left shunt. So possibility a shunt, left to right shunt. And with history also is suggest of left to right shunt, that is recurrent pneumonias, failure to thrive, and CCF features. These are more in favor of left to right shunt. So then what is the exact left to right shunt? You could see a PDA, a VSD, or ASD. ASDs are usually present in later part of life, and PDA are usually present in earlier part of life, right from 1 month, 2 months only. And you have a predisposing history, I mean preterms, usually seen in preterms. So and in terms of incidence wise also, VSD is most common when compared to PDA. So 25% of the congenital heart disease are VSDs in nature. So when it comes to incidence, epidemiological also importance as well, you can conclude that VSD is the possible etiology. Then severity of illness. So severity, whether it is mild, moderate, severe. So mild VSD, then there is no question of a clinical presentation. Most of the times it's asymptomatic. Then moderate, you will have a recurrent pneumonia history, and you have a higher grade of murmur. I mean, not a grade 3, grade 4, grade 5 kind of murmur. And moderate kind of VITs, there won't be any. I mean, they will have a growth defect, but not that much segment. All will be in a moderate range. And so when it comes to severe, so here the VSD is severe because child is having CCF, child is having recurrent pneumonia, the growth is getting affected. And look at the murmur. Murmur is also is of low grade, I mean grade 3 only. So that's how you can figure it out to a large VSD, not severe, large VSD. Then are there any associations like primary arterial hypertension, CCF, infective endocarditis, protein energy malnutrition? No, this child is not having any pulmonary arterial hypertension. So how will you figure out pulmonary arterial hypertension from the history? One thing is looking for percussing the left second intercostal space. So normally left second intercostal space is resonant in nature. If it becomes dull, then suspect pulmonary arterial hypertension. Then look at the second heart sound. If there is a normal physiological split, then PAH is unlikely. If the second heart sound becomes single and loud, then possibility of PAH. Then CCF, obviously here the child is having CCF history in the form of feeding difficulties, excessive perspiration on the head, and even your examination has suggested you that child is having cardiomegaly, and bilateral basal crepitations are there. So CCF could be a possibility. Infective endocarditis is unlikely in this particular child because there is no prolonged febrile illness and there is no hematuria, I mean cola colored urine, there is no splenomegaly, and there is no rashes over the body. So infective endocarditis is unlikely. Then protein energy malnutrition. Here the child is having protein energy malnutrition because the weight is affected predominant, I mean significantly. So weighing around only 4.5 kg. So that's how you need to conclude the final diagnosis. So you need to describe in terms of cardiac problem or not, whether it is a congenital or acquired in nature, whether it is if it is a congenital, it is a left to right shunt or right to left shunt, basically cyanotic or acyanotic. And then exact nature of congenital heart disease, whether it is BSD, ASD, PDA. And then severity you need to describe, you need to describe the association, PH, CCF, infective endocarditis, and protein energy malnutrition. So then further questions like what investigations you will ask for. So CBP, CRP, blood culture and sensitivity, chest X-ray, ECG, 2D echo. So some examiners include chest X-ray and ECG as your clinical scenario only. So they don't consider it as a separate investigations. They club it with the examination part only. So what is the importance of CBP in this particular child or in general a cardiac patient? Look at the hemoglobin. So here child is having pallor. Look at anemia. You need to look for anemia. So if it is a significant, then child might require blood transfusion because to decrease the burden on the heart. Then CRP. So child is having history of fever looking like a pneumonia. So you need to do CRP and blood culture as well. And look at the chest X-ray. See here chest X-ray. What are the findings you can conclude in a chest X-ray? Here the child is having cardiomegaly as well as you could say pulmonary vascular congestion. So you see the pulmonary markings throughout the pulmonary fields beyond two-thirds of the pulmonary area. So pulmonary congestion is there, cardiomegaly is there. So these are the findings you get. And then ECG, you look for axis deviation. So whether it is left axis deviation, right axis deviation. And then look for hypertrophy, ventricular hypertrophy kind of stuff. Then obviously you will confirm the diagnosis by 2D. That's how the investigations you need to see. Then these are the often asked questions. How do you manage this case? What is the most common congenital heart disease? So let's summarize. So basically the histories in a cardiac case, the history serves you in identifying, in delineating the exact, in localizing the cause, whether it is a cardiac or respiratory in origin. And from history also you will come to know whether it is a congenital or acquired. Then uh, then whether it is a left to right shunt or right to left shunt. Then if it is a left to right shunt, then if it is a VSG, ASD or PDA, and then association. So these are all things you need to figure out in the history and examination of a cardiac child. So thank you. That's all for today.